for the computer. We're going to share screen, PowerPoint here. Okay, and here we go. Okay, everybody see? So it's about 80 some slides today. Some pictures mixed in, so it's not 80 slides of info. So we should be able to finish within the hour and hopefully go to lab right around lunch and finish up those last 15, 20 minutes in there. Subcutaneous mycosis. So these are, we had superficial last time. So these are fungal infections that have moved from just being on the surface of the skin as to inside into the deeper layers of the skin. So subcutaneous, under the skin. Cellular response is now in play because we've broken, or we're breaking, the initial barrier, innate barrier of the skin. Infection is a result of a traumatic implantation of the fungus into the tissue. So you may think of simply as, I know it may not seem as traumatic to some, but just getting a splinter under the skin or in the skin, and that could be the entryway. So just simple as a splinter could be the problem. Chronic subcutaneous infection that may spread to other organs. So it starts subcutaneous with that, say, a splinter, and then it moves into the body and goes past the subcutaneous layer. So we'll start out with chromoblastomycosis, and of course chromo meaning color. So these would be a chronic subcutaneous infection, demataceous fungus into the skin, having dark pigment. So a dark pigmented fungi here. A lesion, small discolored papula, then it becomes a nodule, and then if it stays untreated, it turns into the cauliflower, wart-like lesion with red, violet, gray colors, and the patient has a chromoblastomycosis, experiencing little, if any, pain. So even though we'll see a picture in a minute that looks just awful, patient is not experiencing pain with the subcutaneous. And that picture is here. So of course this is a drastic picture. Get your attention for subcutaneous chloroblastomycosis. But definitely, to me, that reminds me of like a Halloween costume of a glove you used to buy at the costume to make your little evil scary. They're sclerotic bodies, so that is new for chloroblastomycosis, round, oval, thick-walled brown cells with cross walls in the two planes. The etiological agents that you're supposedly reviewing, right? Reviewing for your lab exam next week. Mycoses, pedrosoi, Cladophiliophora caroni, Phyllophora verrucosa, Mycoses compacta, and Rhinocladiella aquaspersa. So some great names into the subcutaneous mycosa family. Again, habitat, soil, and decaying matter is, so, you know, we think about running around barefooted, working with that kind of, you know, I'm a gardener, I work, you know, lawn care, I'm out digging into flower beds every day. You know, we could see that definitely show up today. So that's that example here of the sclerotic body, right? Description, brown cells with cross walls in two planes. So sclerotic body there. Cladophilophora species. Of course, you've seen some of these where that's that extender that comes off the hyphae. The Philophora. And I'm hoping we haven't done any. So the good thing about the lab today is those I have not taken the cover slips off. So we're actually going to do that all together just to see what putting it on a drop of lactophenol cotton blue looks like. And hopefully we'll see some of these on the screen. Onsesia pedrosoy. So those lead us into what is the mycotomas. So we started with the chloroblastomycosis, and now we're going to mycotomas. These are local, so going from subcutaneous, so we're kind of working our way inward, if you want to think of it that way. The mycetoma, localized swollen tumor-like lesion. So not just this wart-like external subcutaneous wart-looking thing. Cutaneous and subcutaneous going into the tissues, the fascia, and even to the bone. The lesions are pus-filled, abscesses, draining sinuses containing granules, and the granules that you see are interwoven hyphae. So this would be the actinomycotic mycetoma caused by Nocardia asteroides, infecting the bone, moving into a subcutaneous lesion, tumor-like lesion, and moving its way, if you don't recognize x-rays. Among the most common actinomycetes, which causes mycetoma worldwide, mycetomas are slowly progressive, destructive infections, cutaneous, subcutaneous tissue, fascia, and seen here in your picture, bone. So with these subcutaneous mycoses, it's going to bring back a memory from earlier in micro, is that we have half of these mycetomas are produced by fungi and the other half are produced by actinomycetes, right? So remember that is that bacteria, I think it's an anaerobe, right? Actinomyces, that resembles fungi. So we're going to see here that we may end up doing, a lactophenol blue or a wet prep to look for fungi, but we may be doing gram staining to look for actinomyces. So eumycotic mycetomas are difficult to treat. The fungi are resistant to drugs because of bone involvement and the presence of fibrous tissue. So you'll see that anytime a doctor is worried about bone infection, and I know we bring in phlebotomy from time to time, but you hear untrained or not properly trained phlebotomists that are doing finger sticks on babies and potentially infecting bone, right? You nick the bone with the lancet with a little baby finger. That's not how you haven't waited till they're a year old or more. So that's why heel sticks are still preferred and should be required for any infant baby under a year old. You should go to the heel, not finger sticking. So a little flash into phlebotomy for you. The distinction between the actinomycotic and the eumycotic, remember that the actinomycotic are caused by bacteria and the eumycotic are going to be caused by fungi, is the treatment regime. So you can understand that a subcutaneous fungal infection, they're saying surgical excision, affected tissue or an amputation, extreme. Approximately 70% of the mycetomas involve the feet. Other areas include hand, arms, and lower legs. Differentiating the actinomycotic, which we just kind of introduced earlier, and the eumycotic is going to use the wet prep, potassium hydroxide, revealing the septate hyphae, where the actinomycotic, remember being a bacteria, our gram stain of the exudate reveals the presence of the branching gram-positive filaments diameter, as well as the coccoid or bacillary forms. Sorry. So from our lecture here, the eumycotic mycetoma, Matarella, Acremonium, aspergillus. And then the one for United States, the most common cause of subcutaneous mycosis of eumycotic mycetomas are Pseudosporium apiosperma. And I think we had that one on our list to look at on Thursday, right? A week from today. So we have some pictures, of course. So here's a mycetoma on the foot. Remember, that's where the majority of them occur. So we'll move to the phaeohyphomycosis. Phaeohyphomycosis. These are subcutaneous infections involving fungi that have dark pigmented hyphae, which are seen in the tissue. Sclerotic bodies here are absent. So we don't see that, sclerotic double cell, brown double cell, divided cell. And these are known in the phaeohyphomycosis. The etiological agents here are alternaria, curvularia. I think we have curvularia, today, exophilia, philophoria, and bipolaris. Our species names with our phaeohyphomycosis. So we would expect to see these growing with dark pigments on our plates, and we do see that. To diagnose these, because they're fungi are common contaminants, they can be found already on the skin, transiently on the skin. Clinical information and detection of fungal elements is most important for diagnosing. So here's our phaeohyphomycosis pictures. Another stain. So that brings us to sporotrichosis. These are fungal disease caused by Sporothrix skenici. Lymphocutaneous sporotrichosis. So these are ulcerative cutaneous lesions that end up in the lymphatic system, the lymphadenopathies. So they've migrated deeper. So here you see the thorny plant. If anybody's ever gone out and done any grooming of your flower beds or your mom's flower beds, what are they? The rose bush that you can't kill, or you got to try real hard. The knockout rose bushes that you can put anywhere. If you ever groom those and trim those back so they'll bloom some, definitely you could prick fingers with those thorny plants. Walking through the woods, can come across trees that have really, you've seen the tree, I can't remember the name from my botany, but it has thorns on it, out of the bark on the side. So if you accidentally walk by that, but most of us, I think, have grabbed up clippings of the pruning of the rose bushes, and you know how you could actually prick your fingers. Usually the arms and legs, and if it's untreated, new lesions appear along the lymphatic drainage of the affected limb. So that would be, moving, because the lymphatics, remember, from anatomy, garbage system of the body, takes off all the fluid from excess tissue fluid and returns it into the circulation after it goes through the lymph nodes. Sporotrichosis, not pretty there in that picture. Lesions appear as scaly raised rashes. So these are fixed cutaneous ones. So there's going to be different areas of sporotrichosis. Raised rash, warty ulcerative lesion, found highly endemic areas where population's been sensitized to the organism. Primary pulmonary sporotrichosis. So we've moved from cutaneous to pulmonary, where we inhale the conidia. The disease here is acute chronic pneumonitis resembling tuberculosis. That disseminates. Sporotrichosis, rare form, involves various organs. So we can go from a cutaneous, pulmonary, into disseminating to other organs. The treatment, potassium iodide, if it's subcutaneous, amphotericin B, if it's pulmonary or it's disseminated. So we do have treatment for sporotrichosis. Woody plants, plant debris, wood and soil rich in organic matter. Sporotrichosis is a disease of foresters and gardeners, so I think we've established that. It's often associated with cultivating of roses and other thorny plants, penetrating wounds from the thorns, subsequent infection. So here's one of those famous FYI, just to give you some other names. Of course, we haven't had enough names already for this unit, but lobomycosis, rhinosporidiosis. You see, I just leave that for you. Zygomycosis, Babsioides boilus, Conidio boilus. Some for your FYI, so you understand. Some more subcutaneous mycosis, not always caused by the sporo. So how do we diagnose subcutaneous? Potassium hydroxide skin scrapings, exudates, tissue sections. We can do direct exam. Culture, media with or without antimicrobiotics. The sporothrix is a dimorphic fungus. So we kind of established that. I know you didn't get to see it as well, but we started off putting our yeast and things in the 37 degrees, and then we came out next time and just left them at room temp 25 degrees. So we're trying to go from a yeast cell right at 37 degrees, and then we can change it to a mold form, and the mold forms with the conidia and the rosette formation. So we're trying to capture some of that today with our staining of the cover slides. So that's why we did the switch. So when you hear dimorphic fungus, you think about just as the incubation temperature is one way. So you might have things in your micro lab that you set aside for room temp growing, and then there'll be some things that you'll put in at 37 degrees, and then there might be some that we move up to 42. So most of our micro labs have multiple incubators if they're set up to cover all that, so we can go from all different temps. So if you were guessing, which one would you say this is of the sporothrix? Is this the yeast form or the mold form?
I think mold.
You would be correct. And would you say this is the yeast or the mold form? Allison froze, so I think we lost Alan. Somebody want to help? So if this is the mold form, what is this?
Yeast.
Yeast form. Okay.
I'd go with yeast one.
Okay, yes. All right. So now, so that was pretty much, that was our subcutaneous section of lecture. So now we're moving into the systemic mycosis clinical presentation and diagnosis. Y'all ready? Y'all need a break? Doing well, yes. All right, so coccidioidy mycosis. Oh, we got somebody saying we need, let me pull up. Sorry, my internet's being cracky. Okay. I just didn't want to miss that one. So as you see x-rays. So I know we're not x-ray experts, but we may get tipped off by an x-ray that there is something going on. There is something with the patient that we just did a chest x-ray on that we may be wanting to be involved with. Oops. Did I mess up here? Checking the chat. Blastomycosis. So you're just seeing lungs starting to fill up on these x-rays. If you've never seen an x-ray before, they're supposed to be dark and clear between the ribs. Now this is a good one because this is classic histo, where it just looks like the lung has just been shot with pellets or BBs or something. Looks like it's yeah. So let's start with histoplasmosis. Has everybody heard of histoplasmosis before? Is it a new word? Is it a new thing? It's caused by Histoplasma capsulatum. It affects man and animals. And most of the time we're asymptomatic. Self-limiting disease, if we're immunocompetent, right? So if we're immunosuppressed, then this is where it's a problem. So it disseminates in the patient with impaired cellular immunity. So if you've got cancer, chemotherapy, immunosuppression, kind of our same description that we've had over and over this semester. The disease, 500,000 new cases each year. We'll just go ahead and say it. That is it. 40 million people have been exposed to histoplasmosis. Asymptomatic, mild disease, light exposure, patchy pneumonitis, done. Flu-like illness results from heavy exposure. So if the diffuse pulmonary involvement, necrotic lesions, we get a fibrosis and a calcification with yeast cells in the center. So it can be definitely a lung issue. Chronic disease is seen in middle-aged male smokers. So I know you don't know any middle-aged male smokers. And I don't know, where would you put, like, for me, where would you put me on the middle age? Am I middle age or am I past middle age? Just seeing where y'all put me. Y'all don't have to,
Miss Director.
what am I?
You're young.
Below middle age. I thank you, Heather, for that. That was very nice of you to say. Yeah, but here, lung tissue, cavitary lesions, chronic cough, histoplasmosis, disseminates, hematogenous spread to the spleen, liver, lymph nodes, bone marrow. So it could definitely become a big issue. So here we are. The reason bringing up age, this picture from 1963, a little flashback for history, showing a lab technician, right? We know we're trying to remove that name, but it's hard to remove that name if it's been around for a long time. Geraldine Wiggins performing a chromatographic antigen fractionation. Looking at this lab, kind of reminds me of my old chemistry labs up at Fayetteville. It's kind of what they look like, brown cabinetry with black countertops, kind of old school here. This antigen fractionation consisting of a separation of antigen fraction from Histoplasma capsulatum, using a pH and molarity. Using a shaker, was also about to perform a subsequent agar gel test of the human histoplasmosis serum. So she is definitely old school here. We probably still have all this glassware, and maybe even that, I'm sure we have the stands. No telling what all we still have of that group. So when we think of histoplasmosis, one thing, the reason I asked you, had you heard of it before, because one of the things that definitely arises is for the AIDS patient. AIDS patient loses their cell-mediated immunity. The fungal infection raves on. There's nothing that patient can do to stop. There's little or no immune response. You get these large extracellular masses of yeast with the necrosis. Intracellular leaks may easily be seen in peripheral blood smears. So just a infected patient with a fungi that we should not be seeing at that stage. Definitely not in a peripheral blood smear. I don't know if Ms. Bednar had any of those to show you. I don't think if you did, it would be heme 2. The distribution is a fungus and endemic to the Mississippi, Missouri, Ohio, River Valley. So we're definitely in that area. Soil enriched with bird and bat feces. So definitely one of those that we kind of talked about closing down my haunted house back in my day, which was bird feces. So bird roosting around this time of year in the winter, they'll find a tree that has a lot of leaves and protects them from the weather, and they'll roost in them every night, and they'll poop everywhere. And that's definitely a problem with histoplasmosis here. Avoid chicken coops, of course, and bat caves. So I know bats are fascinating, and you like to get in there, and any cave you've ever walked into around here in Missouri, South Missouri, North Arkansas, you're going to find bats. I think I had a friend that he talks about on Texas State's campus, they have bats that will habitate certain areas, and then they fly out at night. And I don't know if you've ever seen those caves where the bats will leave at night, in hundreds and probably thousands of them leave. So you definitely wouldn't want to go in one of those areas without protection for respiratory, so you don't inhale the histoplasmosis. Birds are not infected. They're asymptomatic carriers, but bats are naturally infected and serve as carriers. So not only are rabies with bats, but histoplasmosis with bats. So here's some stained slides of the histoplasmosis. And then we come across one known as coccidiomycosis. Coccidioidy mycosis. Put in, I forgot my idio there, or idomycosis. Coccidioidomycosis. This is also known as the San Joaquin Valley fever. Infects humans and animals. So, if you're a fan of Joaquin Phoenix, maybe you'll know where he got his name from, San Joaquin. Joaquin Valley infects humans, of course. Coccidioides imitatus is the etiological agent. A mold phase is branching hyaline, septate hyphae, alternating thick wall, barrel-shaped arthoconidia. The tissue phase, spherulums with endospores. So when you think of coccidioides, the reason it kind of gets this name is because of the endospores. So here's that branching hyaline, septate hyphae. That would be the spores inside here. See those? See those? Endospores. Endospores. So with Coccidioides imitatus, we have a disease usually asymptomatic 60%, self-limiting 40%, maybe disseminated and fatal in 0.2%. Inhalation of the arthoconidia from a fertile septa hyphae growing in the soil. Smeriated hot summers, we're starting to see people moving into the San Joaquin Valley for living, and we're going to see a number here in a minute that's going to show us this could be a problem. Disseminated disease, serious infection, cutaneous and subcutaneous tissues, meninges, and body organs. So definitely can go disseminating. It has a life cycle that's kind of going to lead us into next semester, kind of thinking about anytime we see life cycles, we always in micro think of parasites. Life cycle here is there's conversion of the mold form, the septate hyphae, into an infection form, which is a thick-walled barrel-shaped arthroconidia. Through the process where alternating cells between the arthroconidia undergo autolysis to form disjunctor cells, so the alternating thick-walled arthroconidia break off and easily become airborne, and that's the problem. They're inhaled. Okay, so when they're inhaled, the conidia undergo conversion to the spherulomes, 30 to 60 micrometers in diameter, containing the endospores that we just saw on the stained slides previously. And as the endospores increase in size, the thick-walled spherulum ruptures, releasing those endospores, which may remain in the local area of or disseminate. So they may move from the inhalation of the lungs, or they disseminate into the organs. Large number of endospores may overwhelm the host defense systems. These endospores are covered with remnants of the antiphagocytic inner spherulum cell wall. So what are they going to do? They're going to avoid the immune system because they have this covering and can't get attached for phagocytosis. So here is the spherulum with the endospores inside. This is the breaking off of the that is inhaled, and it just has a life cycle that goes on from there. So here is something you'll get familiar with next semester with the life cycles. So we call it a sabrobic cycle and a parasitic cycle. So the sabrotic is outside the body in its environment, in the soil, and then we inhale it and get it into the parasitic cycle, which we inhale, and then those endospores disseminate after they rupture out of the coverings. Southwest United States, Arizona and California prefers alkaline sandy soil. 20 years ago, California had 700 reported cases of valley fever, an infectious lung disease caused by coccidioides. Since then, you see it's climbed steadily to over, in the last 20 years, it's up to 5,000 a few years ago, according to the CDC statistics. So we have Dr. Laura here that said, the professor of micro at Cal State Bakersfield, valley fever is just the tip of the iceberg, trying to sound the warning that it's misdiagnosed and underdiagnosed, and the actual cases may be 10 times higher. So we could be looking at 50,000 cases of valley fever instead of 5,000 a year. Hotter climate, more people moving to the area. Moving on to paracoccidioideomycosis. So this is a South American version, blastomycosis, Paracoccidioides brasiliensis. So you can see South America with the Brazil there. Disease, pulmonary disease, which disseminates to mucous membranes and other tissues. Flu-like disease, asymptomatic, mild, flu-like. Mucocutaneous, chronic disease with skin, mucous membrane, involving oral, nasal, and anal mucosa. Disseminates from the lungs through the lymphatics or blood to the mucous membrane, skin, and other organs, such as lymph nodes, spleen, liver, or bone. Now to blastomycosis. North American blastomycosis, etiological agent here is Blastomyces dermatitis. Inhalation into the lungs. Most infections are asymptomatic. Symptomatic, mild respiratory infection, fever, weight loss, malaise, productive cough. Disseminates from the lungs, spread to the skin and bones, also prostate and testes. So, guys, we would have to worry about that. Skin lesions, ulcerative. Verrucosis, granulomatous processes, diabetics increase risk of disseminating the disease of blastomycosis. Distribution, wheelhouse again, Mississippi, Missouri, Ohio river valleys, Great Lakes area, Mid-Atlantic coastal states. It is a reportable infection for 5 states, Arkansas, Louisiana, Michigan, Minnesota, and Wisconsin. So if you diagnose blastomycosis, you have to report it to the health department. So this is good because you aren't in lab, but this was kind of our lab safety talk. When we ended up in lab this afternoon, just be me. All work should be done under a biological safety cabinet. Good point. Technology should never smell a fungus. Okay, so don't ever just go right in with the lid off and say, well, let me see if it has a smell. Specimens, sputum and other respiratory specimens, lymph nodes, cerebral spinal fluid, skin tissue, and bone marrow. Process them ASAP. Do not refrigerate. Culture media with or without antimicrobial agents, chloramphenicol and cyclohexamine. Time period, we may have to incubate these at room and 37 and hold for at least 4 weeks before we see them show themselves in true fashion. Confirmation, is there conversion of mold to yeast phase? Exoantigen test, immunodiffusion test, patient serum, and cell-free antigen extract to confirm systemic mycosis. All media and reagents and specimens should be autoclaved before disposal. Petri dish should not be used for cultures unless sealed. Bench top should be disinfected daily. Test tube should have screw-type tops. No smoking, eating, drinking in the lab. Immunocompromised personnel should not work in mycology. When using scalpels, tweezers, and needles, be careful. Transfer and work over disinfected soaked towels. All right. So here we go into another pneumocystis, and we see a pronunciation help. And we could have used this like weeks ago, right? For everyone, somebody needs to sit down and just write out all these for me. So we have gyro, kind of like when you go eat the gyros, that but it's kind of spelled different here with a J. Gyrovetsy. So gyrovetsy. If you're having trouble spelling, you might still want to see gyrovecki, as I would say, for spelling purposes only. But it is actually pronounced gyrovetsy. Found worldwide for pneumocystis. Overcrowding areas of the world, orphanages or hospitals with premature or malnourished children. Immunocompromised patient, again with our AIDS patient, 60% of the cases of pneumocystis infection. So again, it's another one of those that you should have, if you followed or listened to any AIDS talks or lectures, pneumocystis. Which way are we going? Gyrovetsy. Gyrovetsy. Okay. Life cycle, transmission, airborne cyst. That's one. That would be how our AIDS patient would inhale it. Transplacental, if it's there, it's stillbirth, if mother gave it to baby. And reactivation of latent infection. Gomori, methamine silver stain, GMS, gray to black spherical bodies, some of which are empty, others containing common shaped inclusions. With gizmo stain, it is 5 to 12 micron size, 8 nuclei in the cyst. And then we see a trophozoite again, sounds a lot like our parasitology coming up. Single ovoid organism with a single nucleus. So those are definitely something that you'll see with parasites, with cysts and trophozoites. The disease is in interstitial plasma cell pneumonia, a severe respiratory illness. Impression smears is specimen of choice, tissue from an open or brush biopsy of the lung collected surgically, thin sectioning, touch prep, fixed stain cytology, tracheobronchial aspirate, another good source, fluid from the percutaneous transthoracic needle aspirate, and sputum here is unsatisfactory. So a sputum from an AIDS patient looking for pneumocystis would not be acceptable. Of course, we just talked about the Gomori, silver stain, and the gizmo stain, and we have H&E stain. Hopefully, if you're looking at the slide, you see the 8. All right. Questions? All right, we're going to stop this share. We're going to leave it recording. And then I will exit and go try to log in into the lab, glove up, gown up, and take my phone with me and hopefully be able to show you some good slides in a minute. All right. Still no questions. I don't see any chat questions. Okay. And we're going to share from in there. So I'm going to try this. So empty chair until you see me in the lab. Oh, I think I'll hit mute here.
Okay. Can y'all hear me?
Yes, sir.
All right, good. Can you see the computer screen up there right now? Do you see a microscope screen?
I think so. From Tuscan or something like that.
Yes. Okay. So I'm going to take that down right now. All right. So now you can see my camera, right?
Yes.
Okay, so y'all see a growth, a plate. See the lactophenol cotton blue. Everybody seeing that? Okay. Everybody see my slide? Okay. Okay. Okay, we're going to pull out Lauren's right here. Everybody see that? Okay. See that? Okay. So, gonna pick one. She says, let's see. We got, let's go with Aspergillus here. Okay, so it's pointing to here, right there. Okay, so what I'm gonna do is I'm gonna take my lactophenol cotton blue. Take a drop. That was awesome. We're gonna drop it here. Okay. And then tweezers. Tweezers. I think I can get it. Carefully removing. Yeah. There it goes. Carefully removing. See? And then we're going to place on the lactophenol blue. Ah, wonderful. Did y'all see that? I'm just going to put the Aspergillus. Okay. So now I'll take this and we'll go put it on the scope and share the screen. Okay? Okay. Share. All right. So I'm just going to give you a view. This is me just first thing I saw. This will work. Not sure it is, but I'll play with this. Try opening it again. In a minute. I'll be asking it to do too much. There it goes. Okay, fine. All right, good deal. Here, you guys back up. Screen. There we go. Okay. Everybody see that? Okay, that's on 10x. Oh, let me get this a little closer so you can hear me. That's on 10x. So gonna just switch over 40. And you see. All right. What do y'all think? Ooh, right there. I didn't quite get the head we were looking for, but that's pretty good. Say for rookie work for me. Okay. Right. Now ready for another one? Let's see. Ooh. Again, this is 10x. Hopefully you can appreciate. That looks interesting there. Let's see. We can focus in on that little guy there. Look at that. There it is. All Okay. Not to blind you. Take this back and stop the share. Make our way back over. Anybody have one more they want to shoot from? We got time to do some more. So on Orange, you see that it had quite a bit of growth moving around. Penicillium looked like it kind of, if you put penicillium on here. So what I wanted to show you, let's show you, we're going to go with, that was Lauren's. Show you Mary's. Mary, you on here?
Yes.
Yeah.
Yeah.
Okay, here comes Mary's. That is some heavy, heavy stuff.
That's gross.
That probably had the most growth of any plate we had. Yes. So we're going to try to, I don't think we even need to try to pick the names, but our penicillin, I think we'll just show what this, look at that. Okay. We'll try one. See what we can do. You see me? I'm going to try to get this one right here. Just see that. Ew. See that slide? Ew. Okay, we're just going to put Mary on this slide. We're not even going to try to figure out which one we have. We're just going to go look for, see what fun we have. Okay, here we go. Okay, y'all ready? Go. There. So this was so heavy on the slide that the stain didn't even get to it. Definitely make out. And when you first look at this one, that's 10x still. So you can imagine. I don't hear any oohs and ahs.
Do we know what this one is?
Not really. It was just such an overgrowth on her plate. I wouldn't even go adventuring as to which one I would label it as. Her plate just was full of ever how many she put on there, it just grew. I'll tell you what spot it came off of. It came off her penicillin. Penicillin spot is where it actually detached from. Oh yeah. So you can start to see that green. Remember when we had penicillin we showed last week or on Tuesday? Remember we showed the actual plate of penicillin? So you can definitely see the green behind it now. So let's take this, let's go a little deeper. Let's go into 40. Let's see what we can find down in here. Find that branch. That might be an end. Definitely get the hyphae, I think. I don't see a good head. That's what I'm looking for. This is about the best I can do, I guess. All right. again. See if we can try another one. I'm gonna get my phone. My phone's running out of power, of course. On this day, it's great. All right, here we are again. That was Mary's. See green, a lot of green. Let's try another. There's a dark one here. This is from Kathy. And I'm going to try this one. See that dark? There it is. See that right there around that one? And she's got it labeled as albicans. So we'll try this one, that dark. If you can see that. See that? We'll do one more. I'm going to try to get that dark one off. Let's see. Drop the lactophenol blue. You see me? Yeah. Feel that? Drop that down on it. Let's go take a look. Okay, let's do this one because this one basically turned into more of a yeast form. So you remember this slide still had white in the middle. Does anybody remember what was the first name of the albicans? What's the first name we're looking at? Candida. Can y'all hear me? Candida albicans. So you see the difference. This is still in the yeast form with Candida. There. I was thinking there was a little bit growing on the side of it. I don't know where it ended up on the slide. This. So that's the big clump that was there. All right. Okay, what do y'all think? Okay, stop share. Okay, I'm gonna take this. Turn my camera. There we go. All right, what y'all think?
That was cool.
Was it cool? Okay. So that was our lab. So you got the slides that have better views, but that was the way you'd go about growing these and fixing them onto a slide and staining them to be looked at to ID. And so we're going to look at the real thing on the slideshow for next week. Again, on the end of Tuesday, we'll review off the PowerPoints there at the end and go over all the little bit of micro in front of mycology that we'll cover on the lab final. Any other questions before I let you go? Thanks for hanging on 5 minutes more than we scheduled. Any questions?
Nope.
All right, hold on just a second. I gotta go into the other room to end. Okay, here I am. Oops.
I'm muted. I found that. All right, so I'm back. Hopefully you saw how that works, that lab, and that would have been just you guys doing the same thing with your 5 and looking at them under the scope. Good deal. All right. Well, do we want to try our picture again? From all your exotic locations for your, there we go. All right. We can get everybody on. There we go. Yay. It's so fun. A few more. There we go. Yay, yay, yay. 3 more. 3 more. Wooey. All right. 1, 2, 3. 1, 2, 3. Here we go. Everybody big smiles. Yay. All right. See you guys tomorrow morning for immunology. Those are there. And we have one question. Be thinking or be looking for it. The question is how long does it take a tumor cell to mutate? Those that hadn't already looked at that, look at that and see what we come up with. All right. Oh, we're getting more. Hold on. We got Zichong and Wooey. If we could get them, we get everybody on here. There's Zichong and Wooey. One more. That way we'll have 100%. Wooey, come on, Wooey. Everybody else is here. 1, 2, 3. Everybody big smiles. One more time. Yay. All right. See y'all tomorrow.